Chapter 32. A greater population does not damage health or psychological and social well-being. The closer man approaches the limits of ultimate density or carrying capacity, the more probable is nuclear warfare. Reed and Lyon, 1972. Most of this book studies material matters usually considered to be in the domain of economics, the standard of living, natural resources, and even the environment. This chapter now goes beyond ordinary economics to discuss health and related issues in connection with population size and growth, mainly because some readers feel that the subject is incomplete without such discussion. In earlier centuries, high population density often affected health adversely. For example, during the Industrial Revolution, the death rate was generally higher in cities than in the country because of poor sanitation and contagious diseases. But though many people still believe that the sparsely populated countryside is healthier than the city, there seems no evidence that nowadays higher population density is unhealthy. If anything, the opposite is true. We'll tackle the issue of physical health first. The effects of population density on psychological and social well-being will occupy the second part of the chapter, along with brief discussion of war. Population density and physical health, feeling and being healthy, is as valuable as anything else an economy can provide. Moreover, health is a central issue in the functioning of the economy. Healthy people work harder and better than sick people, and prevalent illness hinders economic development in many poor countries. Life expectancy is the key measure of a country's health situation, as discussed in Chapter 9 on pollution. There it was shown that population density and growth have no apparent negative effects on life expectancy. Rather, the effects may be positive. In earlier times, living in areas of high population density, cities, undoubtedly reduced one's life expectancy. In the 17th century, when William Petty wrote about London, the death rate was so much higher in urban than in rural areas, and probably the birth rate was so much lower, that cities like London depended on migration from the country to maintain their populations. In 1841, the life expectancy for males was 35 years in London, but 40 years in the rest of Great Britain. And life expectancy in the U.S. was still much lower in urban places than in rural areas from 1900 until 1940 for white males, 44.0 versus 54.0, 1900, 47.3 versus 55.1, 1910, 56.7 versus 62.1, 1930, and 61.6 versus 64.1, 1939. In more recent times in developed nations, however, as communicable diseases have been controlled with sanitation and other public health measures, this disadvantage of population density has disappeared. For example, by 1950 to 52, life expectancy in London had reached 67.3 years compared with 66.4 years in the rest of Great Britain. In most developing countries for which there are data, the death rate is lower in cities than in rural areas, though there are exceptions. As of 1959 to 1961 in the U.S., the death rate was slightly higher for large cities but lower for small cities, compared to non-metropolitan counties. But the high inner-city death rate that explains this pattern is surely due to factors other than epidemic disease, unlike earlier times. More generally, the historical picture in the West during the past half-millennium and in most countries in the world during the past few decades has shown concurrent growth in all three key factors: population density, income, and life expectancy. This suggests that increased density and increased income, either individually or in combination, benefit people's life expectancy and health, as well as vice versa. Consider this example of the health in the good old days in one of the wealthiest and most civilized places in the ancient world, Metaponto, a Greek colony in the south of Italy. In overwhelming numbers, the people had been malnourished, disease-ridden, and injury-laden. 6 out of every 10 had decayed teeth. More than 3/4 had tooth enamel malformed in a way known to be caused by serious disease or severe malnutrition. 56% showed signs of significant disease or injury. Skeletons also revealed a large number of broken bones that had not been set and had healed in distorted way. These findings surprised the anthropologist who supervised the work. You read the literature of classical Greece and you get the picture of a wonderful society, but what we see now is that things were pretty awful. Why is health better where there is higher population density? Let's make a negative point first. There is nowadays no reason why population density should worsen health now that the important infectious environmental diseases, excepting malaria, have been conquered. And malaria, which many medical historians consider to have been the most important of mankind's diseases, flourishes where population is sparse and where large tracts of moist land are therefore left uncultivated. In these areas, increased population density removes the mosquito's breeding grounds. The case of malaria. As Pierre Guru put it, malaria is the most widespread of tropical diseases. It attacks, or did until recently, something like 1/3 of the human race. But in practice, all the inhabitants of the hot, wet belt may be considered to be more or less infected. Malaria weakens those whom it attacks, for the bouts of fever sap their physical strength and make them unfit for sustained effort. Hence, agriculture does not receive all the care it needs, and the food supply is thereby affected. In this way, a vicious circle is formed. Weakened by insufficient nourishment, the infected person's system offers small resistance to infection and cannot provide the effort required to produce an adequate supply of food. The malarial patient knows quite well that a bout of fever may be the unpleasant reward for hard work. Undoubtedly, malaria is largely responsible for the poor health, small numbers, and absence of enthusiasm for work of tropical peoples. In the pre-scientific age, men kept the most serious infectious diseases in check by organizing the total occupation of the land, thus eliminating the breeding places of the mosquito. Such occupation demanded a high density of population and a complete control of land use, and hence the interdependence of a highly organized agricultural system, itself a function of soil quality, reliable climate, and a certain degree of technical competence, a dense population, and an advanced political organization. It is also difficult to improve sanitation and health in sparsely peopled areas. Anti-malarial campaigns stand but small chance of lasting success, whilst the tsetse fly finds such areas very much to its liking, for it is impossible for a population of 10 or a dozen persons to the square mile to keep down the vegetation to a level unfavorable to this insect. Health services are difficult to maintain, and doctors and hospitals are inevitably far removed from patients, whilst education is almost impossible. The data in Table 32.1 support Guru's argument, showing that a low population is associated with a high incidence of malaria on Ceylon. Of course, one might wonder whether population is low in malarial areas because people simply chose to move away from malaria, but the history of Ceylon suggests otherwise. The ancient civilization of Ceylon had centered in the area with hyperendemic malaria. The ruins of 10,000 dams testify to the level and magnitude of this civilization in successive stages of history. Decay of the ancient order was associated with collapse of the irrigation systems, emergence of conditions that favored transmission of malaria, and retreat of the Sinhalese to the non-malarious area of the island. Likewise, some historians have suggested that the decline of the Roman Empire was in large part due to the spread of malaria after political upheaval and decreased population density interfered with the maintenance of the drainage system. Looking now to examples of improvement rather than retrogression, the history of England was heavily affected by the decline of malaria induced by population growth. In London, Westminster was paved in 1762 and the City in 1766, and the marshes near London were drained about the same time. In 1781, a writer observed that very few die now of ague malaria in London. The history of the U.S. also reveals the interplay between malaria, population, and economic development. A mighty influence, buoying up wages paid to the men building canals during the 1820s and 1830s, was the danger of yellow fever and malaria. Built through marsh and swamps, in many instances, to reduce construction problems, the canals were known as killers. As the country was settled, the marshy land where malaria was bred was filled in. Buildings covered the waste spaces where disease carriers could survive. Because of DDT and other synthetic pesticides, medical technologists thought for a time that population density was no longer necessary to prevent malaria. Malaria was considered beaten, but throughout the world, the disease has rebounded. India went from 75 million sufferers in 1953 to 50,000 cases and total control in 1968. But in the 1971 epidemic, there were 1.3 million reported cases, rising to 5.8 million cases reported in 1976, or by another estimate, the number of cases reached at least 30 million and perhaps 50 million. As the use of DDT went down, endemic malaria returned to India like the turnaround of a tide. Also, Sri Lanka reduced malaria from about 3 million cases after World War II to just 29 in 1964. But then DDT was banned, and due to the evolution of pesticide-resistant strains of carrier insects and the concomitant damage to the insect's natural predators, pesticides soon lose their effectiveness. The disease has returned in force. By 1970, Sri Lanka may have had 1 million cases of malaria per year. Barry Commoner gives another example. In Guatemala, some 12 years after the start of a malaria eradication program based on intensive use of insecticides, the malarial mosquitoes have become resistant, and the incidence of the disease is higher than it was before the campaign. The levels of DDT in the milk of Guatemala women are by far the highest reported anywhere in the world thus far. Other public health experts also are grim about the prospects of fighting malaria with chemicals. Asked whether we are winning or losing the battle against tropical diseases, some experts, among them Dr. B.H. Keane of Cornell University Medical College, answer promptly that we are losing. He notes that malaria, for example, seemed almost conquered in the decade or so after World War II. But since then, mosquitoes have become resistant to pesticides, and the malaria parasite has learned to cope with some of the more widely used drugs. Today again, the only sure weapon against malaria seems to be increased population density. Some other health examples. Not only is the infectious disease drawback of population density a thing of the past, but higher density also has many positive effects on health, even aside from control of insects that carry malaria, sleeping sickness, the tsetse fly in Africa, and other diseases. For example, cities in the modern world have safer water supplies than do rural areas. Medical care is better in cities, and medical help arrives quicker or is easier to reach where there is a good transport system, itself the result of population density, see Chapter 25. We must also remember the additional knowledge created by more people that contributes to health. Item: modern emergency medical systems in the U.S. are saving lives after auto accidents and in other emergencies. The population-induced road network of the U.S. is a key to the success of such systems. A country with a much sparser population would find such emergency service much more expensive. And last, it takes imagination and skill, human minds and hands, to invent and develop such medical systems. Item: electrical wiring is now safer than it used to be. Many old houses have been rewired more safely since wiring ideas were developed by additional people, that is, by people who may not have been born if population growth were lower. And new houses are built with safer wiring because population growth, together with increased income, creates new demand for houses. In Ireland, where population has not grown much in the past century, one seldom saw a new building at the time of the first edition of this book. I shudder at the electrical monstrosities that must lie within some of the larger, older buildings. The psychological and sociological effects of crowding. Many believe that high population density has bad psychological and sociological effects. This is mere supposition. High population density has indeed been shown to harm animals, but it has not been shown to harm humans. Rather, it is too much isolation that harms humans. The belief that crowding harms people is supported only by analogies to animals, analogies that are patently misplaced. For hundreds of years, biologists have observed that when animals are confined to a given area with given resources, unhappy events occur. An increased death rate was noted by such observers as Benjamin Franklin. Modern students such as Conrad Lorenz and John B. Calhoun have focused on antisocial and pathological behavior in fish geese and Norwegian rats. For example, the title of Calhoun's famous article is Population Density and Social Pathology. These biologists simply assumed that the same processes necessarily occur with humans. The earliest, and still most crushing, rebuttal is that given to Benjamin Franklin by, of all people, Malthus himself, after he learned some facts and wised up subsequent to publishing his first edition. This episode is described in Chapter 24. Biologist Julian Huxley explains how we go wrong in reasoning from animals to people. We begin by minimizing the difference between animals and ourselves by unconsciously projecting our own qualities into them. This is the way of children and of primitive peoples. Though early scientific thinkers, like Descartes, tried to make the difference absolute, later applications of the method of scientific analysis to man have, until quite recently, tended to reduce it again. This is partly because we have often been guilty of the fallacy of mistaking origins for explanations, what we may call the nothing but fallacy. If sexual impulse is at the base of love, then love is to be regarded as nothing but sex. If it can be shown that man originated from an animal, then in all essentials he is nothing but an animal. This, I repeat, is a dangerous fallacy. We have tended to misunderstand the nature of the difference between ourselves and animals. The critical point in the evolution of man, the change of state when wholly new properties emerged in evolving life, was when he acquired the use of verbal concepts and could organize his experience in a common pool. It was this which made human life different from that of all other organisms. And thus human organization is different from animal organization, especially in people's capacity to create new modes of organization. Here is a similar critique of Lorenz's analogies. Lorenz has a regrettable tendency to describe animal behavior in human terms, married love in monogamous geese, for example. This cannot be dismissed as harmless anthropomorphism in the service of popularization, for it promotes the very misuse of analogy that lies at the heart of Lorenz's problems. A curious twist of logic, to be sure. Impose a human concept by dubious metaphor upon an animal, then rederive it for humans as obviously natural. Thus, a drake that tried to copulate with Lorenz's boot is a fetishist by exact analogy, and a mob of geese frightening off a coati-mundi play the same role as a human picket line. So much for evidence from the animals. Despite common presumption, the sociological data show that human population density, as measured by the number of people per unit of land area, which is relevant to the issue of population growth on Earth, has no general ill effects on such measures of welfare as longevity, crime rates, mental illness rates, and recreational facilities. After it became apparent that the concentration of people into cities is not necessarily connected to pathology, those who worry about these matters turn to crowding at home and work. Here the results are mixed about whether people are affected by crowding as animals are. One study of the effect of household and neighborhood crowding on the relations between urban family members showed that crowding is found to have little or no effect, while Omar R. Galley and co-workers found that a larger number of people per room in Chicago accompanied increased mortality, use of public assistance, juvenile delinquency, and admission to mental hospital. But density and crowding are not necessarily found together. Slums at urban fringes often have low density, and these areas have more pathology than high-density slums. The likeliest explanation of the pathology that Galley and associates found is simply poverty. The most ambitious experimental tests, conducted by psychologist Jonathan Friedman, once an associate of Paul Ehrlich and a believer that density is pathological, led to the conclusions that intuitions, speculations, political and philosophical theory appear to be wrong in this respect. People who live under crowded conditions do not suffer from being crowded. Other things being equal, they are no worse off than other people. It took me and other psychologists working in this area many years to be convinced, but eventually the weight of the evidence overcame our doubts and preconceptions. In any case, the amount of crowding, lack of personal space, has been going down in the U.S. as income has risen, and along with an increase in total population and density in metropolitan areas. The percentage of households living in crowded conditions, more than one person per room, has been 1900 over 50%, 1940 20%, 1950 16%, 1960 12%, 1970 8%. Given that this decline has occurred even as population has been rising, would those who worry about crowding offer population growth as a salutary prescription? Relax, I'm just teasing. Once I had a conversation with a woman who was frantically worried about the ill effects of crowding as we sat haunch to haunch in a football stadium packed with 75,000 people. She saw no humor in my pointing out that she seemed to be enjoying herself tolerably well under the circumstances. Population growth and intelligence. In the first half of the 20th century, many people worried about a decline in human intelligence due to the assumed pattern of differential fertility. The chain of logic went as follows. 1. Poorer families have lower intelligence than richer families. 2. Intelligence is inherited by children from their parents. 3. Poorer families have more children than richer families. 4. The average level of intelligence must fall. This line of argument was again stated by psychologist Richard Herrnstein. Highly competent and respected statisticians and psychologists even estimated the extent of the decline that was supposedly occurring. Cattell estimated that the average IQ is declining at the rate of 3 points per generation. Fraser Roberts reported that based upon his studies of the child population of Bath, England, the fall in average IQ was about 1.5 points per generation. In the United States, Lentz calculated that in the urban population, the decline in the median score from one generation to another was as much as 4 to 5 points. Lorimer and Osborne concluded that the average decline in the median IQ score was 0.9 of a point per generation. It should be remembered that these calculations are theoretical and are based upon observations on a single generation. No one has yet reported investigations of IQ scores in successive generations which support these claims. This idea is then extended by some to assess social policies. For example, consider the following remark in the context of discussion of the Jukes-Kallikak's bad heredity concept. Can it be that our humanitarian welfare programs have already selectively emphasized high and irresponsible rates of reproduction to produce a socially relatively unadaptable human strain? Otis Dudley Duncan criticized this body of thought on both theoretical and empirical grounds. His most telling points are A. The existing studies of IQ change over time did not reveal a decline, but rather an increase, though Duncan did not interpret the apparent increase as being meaningful. And B. Applying the same logic to data on differential height, which in contrast to intelligence is incontrovertibly correlated genetically between parents and children, would lead one to expect a decline in heights from generation to generation, which has not been observed. It is also relevant that persons with severely limited mental capacities have low life expectancies and few offspring, a point which has gotten little or no mention. It is reasonable to assume that a given individual's intelligence, whatever that means, or any aspect of it, is affected by the individual's genes without assuming that there is a correlation between the intelligence of parents and children. It is quite possible that any aspect of intelligence depends upon the combination of a large number of genes which may agglomerate in a random fashion, and hence, while the individual genes are inherited from the parents, the outcome need not be. This is certainly the case among such conditions as mongoloidism. The mongoloids do not reproduce themselves, and yet they continue to appear in each generation, perhaps at a constant rate. And if homosexuality is affected by genetic makeup, the same would be true of that condition. My layman's assessment, lack of empirical support, and the existence of a powerful critique seem to me to overwhelm the proposition that intelligence declines due to a high birth rate among the poor. Yet the apparently plausible belief continues to reappear in each generation. As to the effect of family size on children's intelligence, the evidence is so mixed that it defies summary. Whatever IQ differences exist among children in families with 1, 2, or 3 children are small by any meaningful measure. Other reviews offer conflicting points of view. There is little doubt that, on average, children with no brothers or sisters do worse than children with 1 or 2 siblings. On balance, there is little reason to believe that, all else equal, a larger family lessens a child's intelligence or chances in life. And the long-run trend is towards smaller families anyway, as populations grow and countries develop, so all else is not equal. Population density and war. War between and within nations is perhaps the most grisly outcome that population density or growth is said to threaten. Expanding on the chapter's headnote, the common view is as follows. At the present rate of world population increase, overpopulation may become the major cause of social and political instability. Indeed, the closer man approaches the limits of ultimate density or carrying capacity, the more probable is nuclear warfare. This popular view is espoused by the U.S. State Department, AAD, and CIA, and has been the justification for population control programs abroad. See quotations from the secret National Security Council Plan of 1974, declassified only in 1989, in Chapter 36. The simple fact, however, is that there is zero evidence connecting population density with the propensity to engage in war or even fistfights. A book-length, cross-national, statistically intensive multivariable study by Douglas A. Hibbs, Jr. found that, other factors held constant, the rate of population growth does not influence magnitudes of mass political violence within nations. And in a study of 6 measures of political instability in Latin America between 1968 and 1977, Alfred G. Cousin found no reason to believe that either population growth or density is a cause of political instability. Nazli Chukri concluded that what she calls demographic factors sometimes lead to conflict. But the key demographic factor in her analysis is the relative rate of increase in ethnic groups, rather than increase in population size or population density per se. This can be seen most clearly by listing the wars that she considers archetypical cases of population dynamics and local conflict. The Algerian War of Independence, 1954-62, the Nigerian Civil War, the 2 wars involving Indonesia, the conflicts in Ceylon and El Salvador, Honduras, and the Arab-Israeli series of wars. None of these seem, to my layman's eye, to be conflicts undertaken to obtain more land or mineral resources so as to increase the standard of living of the group initiating the conflict. To show that population growth causes conflict, one would need to show that 2 neighboring countries or groups, both of whom are growing rapidly, are more likely to come into conflict than 2 neighboring countries or groups, neither of whom are growing rapidly. This Chukri has not shown. In Chukri's way of looking at the matter, conflict could as easily be caused by one country or group reducing its growth rate relative to another country or group as by one increasing its relative growth rate. And in fact, many have argued that it was just so in the case of France and Germany, that France's low birth rate induced the French-German wars. Furthermore, as we saw in the afternote to Chapter 29, the traditional economic motive for war, acquiring farmland, is fast disappearing. For economically advanced nations, it doesn't pay to make war to get another nation's agricultural territory, and a sensible citizenry wouldn't even take a slice of another country as a gift. What then determines health? If population density and growth are not the determinants of health in the short run, what does determine how sick or healthy we are? By now, the answer has become clear. A community's health depends upon A, how much scientific knowledge has already been discovered, which is much the same as asking which year we are talking about, and B, how economically advanced the community is. We also know more now about what causes modern populations to become less healthy. Bad government, for example. One channel through which bad government harms people is through pollution. It now is clear that the recently socialist countries in Eastern Europe have very high levels of pollution, both because socialism made them poor and because socialism predisposes to pollution over and above the income effect by emphasizing production at any cost. Data on life expectancy in Chapter 11 showed that low income and socialism also predispose to high mortality rates, and that some mortality rates have even been rising in the recently socialist countries, especially in the working ages for males. See also Figure 32.1 for the old Soviet Union. The morbidity for all causes except cancers, which one generally suffers from only after living to an old age, and auto accidents, which require that the society have many vehicles, are higher in recently socialist countries, and the unfavorable ratio for socialist versus non-socialist countries is increasing, as Figure 32.3 shows. Even infant mortality rose in the Soviet Union from the 1970s, though not in the rest of Eastern Europe, in contrast to experience everywhere else in the world. The high rates of alcohol and cigarette consumption in Eastern Europe are interesting in this connection, see Figure 32.4, though subject to several interpretations. Because factors other than population density and growth explain much of the variation in health, now as in the past, the argument that higher population density does not damage health is strengthened. In the very long run, then, population growth leads to better health because it leads to more discovery of new scientific knowledge, see Chapter 26, and to economic advancement. Regarding the purported ill effects of population density, the charges are many and imaginative. The chapter covered the main ones that people have written about, though there are many other ill effects of population density that one may concoct. The overall verdict must be innocent. And this is not for lack of evidence. As the most recent extensive review sums up, it is reasonable to conclude that the density pathology hypothesis fails to be confirmed within urban areas. When social structural differences among neighborhoods are considered, held constant, population density appears to make a trivial difference in predicting pathology rates.